Hi, I'm Nicole or Coco.
Hi, I'm Jayla.
Hello, I am Savannah, and today our group will address one of the most significant yet frequently overlooked challenges in geriatric nursing: the effective and ethical management of pain in older adults. As we progress through this presentation, we want you to view pain management not just as a clinical task, but as a fundamental human right and a core component of preserving a patient's personhood. In the geriatric population, where cognitive decline often silences the patient's voice, our role as nurses shifts from simple caregivers to essential advocates. We will be drawing on high level evidence from the last 3 years to show how we can bridge the gap between silent suffering and clinical excellence. We are currently in the midst of what experts describe as a crisis in geriatric care: the systematic undertreatment of pain. This issue is particularly acute among frail seniors, those with a loss of physiological reserve who are uniquely vulnerable to the stressors of untreated pain. The complexity of this issue stems from a triple threat. First, the physiological changes of aging alter how pain is perceived. Second, multi-morbidity creates overlapping sources of pain. And third, communication barriers like dementia often mask pain as agitated behavior. If we misinterpret a scream or a frown as a behavioral problem rather than a cry for help, we fail in our basic moral obligation to relieve suffering.
To understand the urgency of this topic, we must look at the numbers. By 2050, 1 in 6 people globally will be over age 65, meaning this challenge will only grow in scale. In our current nursing homes, the prevalence of pain is staggering, with studies showing up to 85% of residents suffering from persistent pain. We are also seeing a rise in neuropathic pain, which affects nearly a third of this population due to neurodegenerative diseases. Perhaps most distressing is that over 70% of end-of-life patients continue to experience moderate to severe pain in their final hours. These statistics are not just numbers. They represent millions of seniors whose quality of life is being destroyed by depression, insomnia, and functional impairment caused by unrelieved pain.
Today, we will move through a logical progression of evidence and ethics to address this crisis. First, we will synthesize 3 major evidence-based themes: validated observation assessment, the ethics of opioid stewardship, and multimodal non-pharmacological care. We will then evaluate current nursing practices, identifying specific findings from recent literature that highlights both our successes and our gaps. We will conclude by diving into legal and ethical implications, such as accessibility and the conflict between autonomy and comfort. Before providing a strategic summary, how you can implement these changes at the bedside tomorrow.
Theme 1, Validated Observational Assessment. Our first theme focuses on standardizing the silence. In geriatric care, the gold standard of pain assessment, the patient's self-report via a numeric rating scale, is often impossible to obtain due to advanced dementia. Research shows that dementia actually dysregulates pain processing, meaning the patient might feel pain but cannot map it to a 0 to 10 scale. As nurses, we must shift our expertise towards behavioral indicators. This means becoming behavioral decoders who look for specific signs. The furrowed brow, the low-level groan, or the rigid body posture that signals distress when words fail. Implementing behavioral scales. To make these observations clinically useful, we must use validated tools like the BPS-NI and PAIN-AD-G. A 2023 study by Wandry et al. Found that the BPS-NI has substantial agreement among clinicians, meaning it provides a consistent, objective language for the nursing team. Most importantly, this research established a clear cutoff values. A BPS-NI score of 4 indicates moderate pain, while a 5 indicates severe pain that requires immediate intervention. By using these specific thresholds, we move away from subjective guessing and toward a data-driven standard of care that ensures no nonverbal resident is overlooked.
Theme 2 addresses the assess abyss. The reality that many seniors are losing access to essential medications due to the general opioid epidemic. While opioid stewardship is vital for the general population, recent literature argues that applying these same restrictive policies to the frail and dying is cruel and degrading. We face an ethical tension. Non-maleficence warns us of the risk of sedation and fault, but our duty of beneficence mandates that we relieve suffering. We must remember that for moderate to severe geriatric pain, essentially at the end of life, opioids remain an essential component of professional care. One of the greatest barriers to effective treatment is opioid phobia, or the fear of hastening death. To combat this, we must rely on the doctrine of double effect. This ethical principle justifies the use of high-dose analgesia if the primary intent is to relieve suffering, even if it leads to physiological decline. Furthermore, the risk of diversion or addiction is significantly lower in long-term care settings due to the high levels of accountability and control distribution of every dose. By ensuring that naloxone is promptly available for accidental overdose, we can safely prioritize the patient's dignity and comfort over institutional fear.
Theme 3, multimodal and non-pharmacological strategies. Because older adults are psychologically vulnerable, We cannot rely on medication alone. As nurses, we must be experts in multimodal care, which use different types of therapy to reduce the pill load. Recent systemic reviews highlight the analgesic potential of non-drug interventions, specifically electric and magnetic therapies, which have shown statistically significant improvements in neuropathic pain. These therapies particularly valuable because they avoid devastating side effects common in geriatric patients, such as hyponatremia from SNRs or CNS depression from gabapentinoids. Practical non-drug care is not extra work. It is the core of evidence-based nursing. Texas Health and Human Services mandates that these interventions be person-centered and integrated into the facility's QAPI plans. This includes physical interventions like repositioning, heat cold packs, and exercise, as well as psychosocial tools like mindfulness meditation. Even when raw pain scores reduction is small, these methods are highly acceptable to patients and provide a synergic effect when used alongside low dose medications, allowing us to find the sweet spot between relief and alertness.
Finding 1. Our first major finding from the literature is a critical knowledge gap in assessment. In many facilities, nurses are still treating agitated behavior with psychotropic chemical restraints rather than identifying the underlying pain. This is a failure of nursing excellence. Psychotropics significantly increase the risk of sedation and falls and are now tracked as negative quality measures. The evidence is clear. If we adequately address physical comfort first, many of these mood and behavioral disturbances resolve on their own. This restores the patient's ability to interact with their environment. Finding 2. Finding number 2 is the pervasive stigma and opioid phobia among healthcare staff. Nurses frequently report a fear of facing legal or professional licensing consequences if they provide the high doses of analgesia required at the end of life. This fear leads to a declining standard of care where patients are left to endure avoidable suffering because the nurse is more worried about a regulatory survey than the patient in front of them. We must shift our professional culture to recognize that failing to relieve suffering in a vulnerable patient is the true ethical violation. Finding 3. Finding 3 highlights the biological uniqueness of the older adult. Due to reduced lean body mass and an increased fat to water ratio, the distribution of drugs in the elderly is highly unpredictable. Furthermore, reduced renal and hepatic clearance means that drugs stay in the system longer, narrowing the therapeutic window and increasing the risk of toxicity. As nurses, we are the primary safety barrier. We must be the ones to monitor for the specific toxicities like electrolyte disturbances, a younger patient would easily clear, but that could be fatal for a frail senior.
To fix these systemic issues, we recommend 3 key practice changes. First, mandatory annual training for all staff on validated behavioral pain skills is non-negotiable. Second, we must systematically implement the Pain Ad or BPSNI for every non-verbal resident during every shift, not just quarterly. Finally, we should embrace emerging AI-assisted facial analysis technologies. Recent studies show that AI algorithms can detect subtle cues of suffering that human observers might miss, providing 24/7 symptom monitoring for our most vulnerable residents. We must be realistic about the barriers that we face. Staffing shortages are the number one institutional hurdle. When a nurse is overwhelmed, comprehensive pain assessments are often the first thing to be rushed. We also face the persistent myth among families and even some clinicians that pain is a normal part of aging. This belief leads to the minimization of symptoms and under-reporting. Finally, restrictive scope of practice laws for nurse practitioners in some states limits the timely prescribing of opioids, creating unnecessary delays in relief for the dying.
Group thoughts on nursing evaluation. As a group, we concluded that nursing advocacy is the bridge between silent suffering and client relief. We believe that the standardization of assessments through validated tools is a matter of safety, not just convenience. Our final thought is that fight against the access abyss must start at the bedside. If we don't document the pain through the evidence-based scales we've discussed today, the physician will never have the data they need to order the necessary relief.
Issue 1. Our first major ethical issue is the tension surrounding autonomy. Many older adults have conflicting values. Some want to be totally pain-free, even if they sleep through their final days, while others want to be lucid and awake to talk to family, even if they hurt. When cognitive decline is present, we must rely on advanced directives or substituted judgment. However, we must also consider that chronic pain itself destroys autonomy by trapping the patient in their body. Therefore, relieving pain can actually be a way to restore a sense of self. Issue number 2. Issue number 2 is justice and equity. We must confront the reality that your zip code often determines your access to pain relief. There are massive regional disparities between urban and rural palliative care. Furthermore, legal frameworks designed to stop street addiction are penalizing the terminally ill, creating a justice gap where the most vulnerable pay the price for the actions of others. We believe that pain relief is a fundamental human right that must be provided regardless of a patient's geography or socioeconomic status. Issue number 3. Our third issue is the classic medical ethical balance, doing good versus avoiding harm. Failing to relieve the suffering of a frail elder is considered inhuman and degrading. However, we also fear social death, where aggressive sedation makes the patient unreachable for their family before they can actually pass away. This requires the nurse to use contextual judgment, constantly titrating the medication to find the perfect balance between physical comfort and the preservation of human interaction.
Legal ethical practice changes and barriers. The most critical practice change for these dilemmas is the early integration of interdisciplinary teams. We cannot wait for a crisis to call in the chaplains or the social workers. We recommend using substituted judgment as a standard when autonomy is compromised, ensuring family is a part of every decision. The biggest barriers here remain outdated advance directives and these intense family conflicts. As nurses, we must often act as mediators to ensure that the patient's comfort remains central goal despite these outside pressures. Group thoughts on legal ethical implementations. Our group strongly believes that relief of pain transcends policy. The national response to the opioid epidemic should not negate our individual ethical duty to a person in the bed. We believe nurses must exhibit moral courage, the willingness to question restrictive order, or speak up for a nonverbal patient when others are silent. Finally, we believe that ethics must be a part of mandatory staff training along pharmacology so that nurse feels empowered to make these difficult decisions.
To summarize the highlights of our presentation, success in geriatric pain management requires a triad. First, we must use validated behavioral tools like the BPSNI to give a voice to the voiceless. Second, we must use a start low, go slow, multimodal approach that utilizes non-drug therapies to protect the fragile body. Finally, we must recognize our ethical duty to treat as a moral imperative that overrides the stigma of the opioid crisis. By following these principles, we preserve the dignity and excellence of the nursing profession. By utilizing these evidence-based findings, we can ensure that every older adult in our care receives the humane, dignified relief they deserve. Think about the care that you want to receive in the future and make sure those in your care receive it as well. Thank you.